may I now request Dr. S. Maniram Krishna, Consultant Pediatric and Fetal Cardiologist, Tiny Hearts Pediatric and Fetal Clinic, RK Hospital, Thanjavur, to walk us through the intricacies of fetal echocardiography and genetics of the congenital heart disease. Maniram, sir, please.
Thank you, Sajani, Appu, and Hari for giving me the opportunity to talk in this forum. Can you see my screen?
Yeah.
Yes, sir. Yes, sir.
So I'm going to talk about the importance of fetal echocardiography and genetics in congenital heart disease. It's going to be a very short talk, and I promise you there will be not much of technical terms involved in this talk. There will be only 2 slides on technical terms, nothing more. Now, whenever as a layperson we hear of heart disease, our perception is either a very old person, our grandfather, or one of our great uncles or aunts with some chest pain who gets admitted in the hospital, has a procedure, bypass surgery, and all that. Or because Valentine's Day is coming soon, we might be thinking of young people with heart breaks. So that is what we think of as far as heart diseases is concerned. But heart disease can occur in children as well. And these heart diseases, as Sunil sir explained and as Amol also explained, can be of very different types. So there can be holes in the heart. There can be a chamber in the heart which is not at all formed. There might be a valve which does not either open properly or close properly. Or some of the big blood vessels in the heart may not be arising from where they should come. So something which should come in the right side may come from the left side, and vice versa. So these are what we call structural heart diseases. And these heart diseases are more common in children rather than the other types which we associate with adults. So why are we worried about CHD so much? The reason is, if any pregnant mother who has met an obstetrician would have heard about Down syndrome, about the importance of screening for Down syndrome, because it can be found in the in early pregnancy itself. So that is not every obstetrician talks about the importance of Down syndrome to every prospective mother. And the incidence of Down syndrome is 1 in 700. And even though we can do a lot of things to improve the quality of life of children with Down syndrome, there is no cure for the syndrome per se. Then there are some diseases which get a lot of importance. One such thing is neural tube defects. So neural tube defects is where part of the head or part of the spine is not formed at all. The back or the head is not formed at all. It's one of the it is one of the most severe congenital anomalies with an incidence of around 1 in 1,000. And the most common forms of these neural tube defects are actually incompatible with life. So there's no way a child with this defect can survive after birth. Yesterday, I attended a seminar in our local pediatric forum on diabetes in children. And there was a huge attendance, like almost the entire pediatric community had turned up for this seminar for a disease which has an incidence of around 1 in 6,000 or 1 in 10,000. And even with proper care, the quality of life may not be perfect in all these children. And finally, we come to congenital heart disease, which have an incidence of 1%, that is 1 in 100. And unlike most of these diseases, as Sunil sir mentioned, the commonest ones can be completely cured. You need not even follow them regularly. Once they have their surgery, they can lead a completely normal life. And even in the uncommon ones, with palliative procedures, yes, they may need repeated procedures, but they generally have very good or excellent quality of life in almost all the types of congenital heart disease. So we have a common problem, and we have a problem for which good solutions are available. And if you take a more focused subset called critical CHD, so this is approximately 1 in 3 of all CHDs. And these are diseases which, if we don't identify and treat them in the correct time frame, like Amol's child, they can result in either death or very significant disability. And that is why we are talking about these challenges. So what are the challenges facing these parents with CHD? Some of them have already, Amol, from a first-person experience, has already told us about quite a few of these problems. The first is lack of awareness about management options. The second is, even though we have facilities all over the country, they are still few for our population, and families have to travel a really long distance. The third, again, is the cost involved in the management. And the fourth is social stigma associated with heart diseases. Now, if you take the first three problems, they can be overcome if we have adequate time to understand and explain the problem to the parents. And with critical CHT, the major problem is you may not have time to overcome these challenges because you need to treat the baby as soon as possible, which is where I believe fetal echocardiogram has a role to play. So what is a fetal echocardiogram? So this is a scan which is performed during pregnancy, which can look at the heart and diagnose almost all of these critical congenital heart disease. So it is best performed at 5 months of pregnancy, between what we call 18 to 22 weeks. But a very skilled operator can even recognize this in the third or fourth month. So I'm going to explain this importance by a real life story actually. I don't know if there are fans of Kamala Hassan here, but one of my favorite movies of Kamala Hassan is Apurva Sahodharakal. So essentially, the essence of the story is two people from the same background. They traverse through different paths of life and then come to the conclusion. So I'm going to tell this through a story of two babies, baby S and baby K, I'm going to call them, who had very similar heart diseases. Now, both of them had a condition called aortic interruption, wherein there was not enough blood going to the abdomen and the legs. So this needed to be identified and treated within the first few days of life. Otherwise, the baby was going to die without treatment. Both babies are going to die without treatments. And their story is in essence the story of the congenital heart disease scenario in central Tamil Nadu where I live. So baby S was born in Perambalur, which is a sort of backward district in Tamil Nadu. Baby K was born in Thanjavur. Now there is pediatric cardiac facility available in Thanjavur, which is probably the only facility for 8 to 10 districts in central Tamil Nadu. But even here, neonatal surgery is not available. So you either have to go to Coimbatore or Chennai, which is the westernmost or northernmost corner of Tamil Nadu, in order to undergo neonatal heart surgery. So how did baby S fare? So this baby was born at 8 o'clock in the morning in a private hospital in Perambalur. So the baby was completely fine. The family were very happy. This was the first baby for the parents. Everybody in the family was very happy. And then the pediatrician went back and saw the child 4 hours later because the nurse said the baby's breathing is not looking good. And he noticed that the baby was breathing very fast. So he thought this baby may need some advanced care, which was not available in their hometown. And so he referred them to a tertiary facility in Trichy, which is a bit more than an hour away. So the baby reached that facility at 2 p.m. So there the baby was received, so initial treatment was given, the baby was stabilized. And then the pediatrician at the tertiary care facility, he kept seeing the baby throughout the day. At 6 o'clock, he was not happy with the response to the treatment. So he believed he was not treating it the way it should be and that there is something else which he was missing. And he thought the thing which he was missing could be potentially a congenital heart disease. Now, unfortunately, he did not have a pediatric cardiologist available in Trichy also. So he had to refer the baby to me for a diagnosis. So the baby had, a baby who's less than 12 hours old had to make a second journey, again in a new ambulance, to Thanjavur, where I performed an echo at 8 p.m., exactly 12 hours after the baby was born, and confirmed the diagnosis, and started the baby on some life-saving medications to stabilize the baby initially. But that was not the end of the journey. Even though we knew the diagnosis, we knew what treatment is needed, the treatment could not be offered at Thanjavur. And so after the initial stabilization, which took almost a day for us, the day after, the baby had to be shifted from Thanjavur to Coimbatore, where the surgery was performed. Now, what are the challenges facing the family? First was a scattered family. The mother and grandmothers were in Perambalur. One grandfather was in Trichy, settling the bills for the initial hospital where the baby had been stabilized. The father and one of the grandfathers were with me. And this was a complete shock. In the morning, they were celebrating the birth of their first child. And suddenly there was so much information for them to digest and internalize and understand, all within a period of 12 hours. And, the pediatrician in Perambalur thought something, the pediatrician in Trichy thought something else, I am saying something else. It was very difficult for them. But more than anything else, what I could make out from the father's face was sheer exhaustion. What was supposed to be the happiest day of his life was spent running from one place to another, one hospital to another, one ICU to another. So that was the primary reaction. He was completely exhausted. Now, the cost of the procedure was approximately 3 lakhs. Both of the families were from middle class backgrounds. So, they would be able to muster that money up. But it's not something which they could, just produce within hours. They needed time to arrange that money, and which they did not have because the child needed to be operated in the next couple of days. And then there was this unexpected leave from work and workplace arrangements. So in this part of the world, paternity leave is not really something, it might be a few days, or if you're very lucky, 1 week. Whereas here you are expecting at least 10 days away from work, and being middle class, you have to work to earn. So this was also in the back of his mind, like how am I going to manage that as well? And he had to do all of that within 1 day. Ultimately, the baby, they managed to do all of that. Despite all the stress, the baby got operated and went home well. But this wasn't the case with the other baby. Baby came. So this was the first child of non-consanguineous parents. Now, this child was born after 3 years of marriage. So, there was a lot of celebration when the mother became pregnant, because in 3 years they've been trying to have a child and they didn't have it. 3 years may not sound a very long time for most families, but for this particular family, both parents were very stressed about the fact that they did not have children. The early pregnancy was uneventful. He was actually referred for routine fetal echo just because the family were too concerned. And at that time, we picked the CHT. Now, this family was also from a sort of middle class background only. The father had just started a business on his own, very small local business, and it was just starting to become slightly financially stable. But as soon as they heard the news, obviously they were shocked and they were completely crestfallen. They could not even internalize what I was speaking to them. But then they went home, and 2 days later, the father came back to me, and then we had a detailed discussion about the diagnosis, the treatment plan, and all of that. This was at the height of the second wave pandemic. This was in May 2021. So we organized for a video consultation with the surgeon because they could not go physically to Coimbatore or Chennai and talk to the surgeon. So the surgeon also explained the management plan and all of that. So they worked out all the logistics and cost of treatment, various possibilities and all that. And the family felt that the best option for them was to deliver in Thanjavur, have the initial stabilization, and then transport the child for surgery, because that might be, logistically and overall cost-wise, they've thought that will be less expensive. And he was able to arrange all of these 3 months before delivery. So it went like clockwork. The baby got delivered, we did an echo, confirmed the diagnosis, and then stabilized the child, shifted the child for surgery, and then the child recovered completely from the surgery. So that is the beauty of fetal echo. You have a control over a lot of the proceedings of critical heart disease, at least. So we were able to take care of the 3 major challenges just because we were able to diagnose it much earlier than when treatment was required. Now, social stigma, I think webinars like these could help remove it in the long term, but we don't have a short-term solution for it at the moment. So how good is fetal echo? It may not pick up all the simple CHTs, the group 1 CHTs, which Sunil sir had mentioned, but it can definitely diagnose all the critical CHTs. It comes with a caveat though. It should be in the hands of a trained operator. So someone who is good in fetal echocardiogram, who has been trained to do fetal echocardiograms, can definitely diagnose all critical CHTs. So every pregnant woman should undergo a fetal cardiac evaluation by someone who is trained to do these procedures. And now my next part is on genetics of CHT. Now, is CHT a genetic disease? We don't have a clear yes or no answer for that. What we do know is, 1% of all pregnancies are complicated by CHT. If either parent has congenital heart disease, that goes up to 2 to 4%. And if CHT is there in a sibling, it may go as high as 5 or sometimes even 10%. But if there are CHT in multiple family members, the risk may go up to as much as 25 to 50%. So there is definitely a genetic component to CHT, but probably not all CHT. Now there are certain perceptions which exist about genetics, and this is not just about a lay person or a general public alone. It even exists among doctors and sometimes even among pediatricians. So some of the myths are, genetic testing is not widely available. That is false. In today's day and age, you can do the genetic testing even in small villages in India. Now, genetic testing, they think, is only one test, one test, and that is the only test which is needed. That is not true again. So genetic testing depends on the type of problem which the baby has. So some certain problems need certain tests, whereas certain different problems need completely different tests. So it's like a horses for courses. You need to know what the problem is, and you need to order the appropriate test for that problem. So it cannot be just one test which gives you all the answers. The third conception is genetic testing is very expensive. That is also not true. The prices in India are probably the lowest in the entire world for genetic testing. And they are also very widely available. People think genetic testing is of no use to this patient's management. That is also not true. Sometimes the outcomes of congenital heart treatment depends on what the underlying genetic problem is. And there are, when you have a genetic problem, there can be associated non-cardiac problems, which we may not even be aware of. So only when we do the test, we will be looking out for these non-cardiac problems, and we can manage them even before they become unmanageable. The last thing I keep hearing is, genetic testing doesn't do anything for the family. And actually, and I'm going to illustrate it with a case, real life case also. This probably has the highest cost-benefit ratio among all investigations we do for heart diseases, other than echocardiogram, when it is used judiciously for the right patient. When the right test is done for the right patient, it probably provides more cost-benefit ratio than any other test which we do. So this is again a real-life couple. They are actually from an upper middle-class background. Consanguineous, married for 3 years. So the first pregnancy, a fetal echocardiogram was done by a radiologist. He was diagnosed to have a single ventricle, and there was a mention of reversal of flow in the PDA. So the complete diagnosis was not put together, but this was what we were able to find out. And the pregnancy was terminated without further evaluation. So this current pregnancy, the obstetrician had seen a scan and diagnosed some heart problem and advised Down syndrome screening at 3 months. So the family came to us at 13 weeks, which is end of 3 months. We did a fetal evaluation. So there was midline liver, there was dextrocardia, there was functional single ventricle, common AV valve, pulmonary atresia. Everything put together was one of the most complex forms of heart diseases which we generally manage. And when I compared it to the report of the first pregnancy, it looked like both the pregnancies had very similar problems. So the family were completely shattered. Their response was, why me? Why did this happen to me? And we were able to sit with them and draw out their family tree. And we realized that whenever marriage within relatives happened in that extended family, there was some or the other heart disease, even though all of them hadn't been perfectly evaluated. There was a suggestion that a death or some disability could be related to heart problems. And we did the appropriate testing for this family, and we diagnosed that they had a very rare form of inherited heart problem, where each parent has a faulty gene. But because the second gene, we have 2 copies of every gene. So each parent had one faulty copy and one normal copy. And the normal copy sort of made up for the faulty copy, and hence the parents were completely normal. But when they actually ended up giving the faulty copy to their children, which is why each of their children had a heart problem, which was a sort of very severe heart problem. And this, can happen with 25% of all pregnancies. So every subsequent pregnancy also has a 25% risk of having this genetic problem. Now, having had 2 children up to 3 to 5 months with a significant heart problem, the family were not willing to go through this process again. And they did not want to, become pregnant again, go on for 3 months, and then realize child has a very major heart problem. And we were able to offer them a solution for that as well. So this is something called pre-implantation genetic diagnosis, wherein by IVF, the family were able to choose a fetus, baby, which will not have all these multiple problems. And the family actually were able to guide them to that facility. They've had this procedure done, and the mother is actually pregnant right now. So only by doing this genetic testing were we in a position to offer such a solution for this family. So I hope I was able to shed some light on these two conditions with my talk. Thank you.
Oh my God, thank you so much, Maniram sir. I mean, we were like, we never knew these possibilities. Because normal kind of scanning and all is done. Like when you're pregnant, you get all those scans and all done. But they never told that this kind of a thing really is there. So I guess we need extensive, I mean, we are not aware of the technical terms and all as we are all laymen. But I wish we had this kind of a knowledge before. I mean, this is what has to go around, and people have to know of it. And the genetic implication is so huge. I mean, if you are aware of any member in your family having a genetical condition wherein they were, I mean, we might get a better solution rather than running around for 101 other possibilities. It's really wonderful, a thing that you have shared, and it's totally new to me. And I'm really excited. And I just wanted to add another question: is like a stem cell research? Is it like a possibility? Like, and the parents, should they go for it? And is it a myth or a reality about stem research?
For congenital heart disease, probably not in the near future. But there are some other forms of heart disease where, even in India, some research is going on the potential for stem cell therapy. Things called cardiomyopathies. Some of them might be, congenital or even genetic. Most of them actually. And hopefully, in the not too far future, there'll be a solution for them based on stem cells. But as far as congenital heart disease, which is our primary focus today, there are, probably not in the near future.
And another question, sir, I hope you wouldn't mind, about organ transplant. I mean, is there any age or is there anything we have to keep in mind if we are like in the future, we are thinking of having, maybe if our kid needs one when he grows up? I mean, what are the possibilities, and how should we be prepared for it?
No, organ transplantation is very much possible even in our country, even in, at least in South India, there are quite a few centers which are offering cardiac transplant. But unlike unlike the liver, where you can take it from a living person, or even kidneys, you can take part of the liver from the father or mother and put it into the baby. You cannot do that with the heart. So you need to take it from a person who's what we call brain dead, who has no scope of living, who's just being kept on, in the ICU on life support. So, and you cannot put an adult heart into a child. So the problem with infants and young children is not that it's not possible. Getting a heart is very challenging. You need to have somebody of that similar age who dies, and that is not very common. And again, we saw that congenital heart disease treatment is available only in few centers in Tamil Nadu. The number of centers offering heart transplant are even less. And with heart transplant, there is a time called cold ischemic time, where within a certain number of minutes, you need to remove the heart from that person who's donating it and put it into the person who's receiving it. So that is very short, it's actually a matter of minutes. So the family have to be in the right place in the right time, apart from the cost and all the other things involved. So that is why, in small babies, it may not, or even in young children, getting a heart in the right time may not happen happen for everyone. So there are other medical challenges as well, which in our country at the moment is probably are insurmountable, but things may change in a few years.
Okay, so no artificial heart and no possibility for that in your future, I guess. Right, doctor.
Again, there is a possibility of things called ventricular assist device, which sort of act like an artificial heart. But such devices for children, probably there are only 1 or 2 centers in the whole country which offer it at the moment.
Okay, thank you so much, doctor. Really, I am really sincerely saying this. I have never thought about this kind of a genetic thing that might trigger and cause this kind of a thing in the. We really need to get into genetic mapping a little bit more. Parents and young couples, especially Valentine's Day, and it's happening, and they might be thinking about being family and all. it is better that they get the checkup done rather than gifting their future wife or husband and whatever gifts. Let them
I
do
think
good.
Mahesh sir may remember this incident. A few years back, we had a visiting pediatric cardiologist from the UK. We had gone out for dinner. And then he was telling us, we have this amazing thing in the UK where for 3,000 pounds, I can look at my entire genome. And then I told him, look, if you come to India, we can get it done for much less than 300 pounds. So you can actually fly first class from the UK, get it done and go back, but at a much lesser cost than what it is in the UK. So, things can be done in India, and things are actually not, the costs have actually come down since then. So it is very much possible. But the most important thing is identifying the problem and ordering the right test for the problem. So it's not like, as I said, it's not like one size fits all. So you need to do the right thing for the right child.
Oh my God, that's really good. Thank you so much, doctor. Really, it was like a very refreshing kind of a thing. And the way you presented also, the pictures and all, that really connected with all of us. Thank you so much, sir. And we are looking forward to more sessions wherein we would be like, we want you here for sure. All of you. I mean, because I'm sure every person who joined the meeting, they came without knowing so many facts and so many uncertainties. And I'm sure your questions, the presentations that the doctors have been presenting, it has cleared so many doubts. And we are in a better position to handle things now. I'm sure of that. Thank you so much, doctor.